Welcome back to Almost Healed, the space where we're almost ready, almost perfect, and most importantly, almost healed. Today's episode is a very powerful one. We're going to be talking about sex, stress, and the pelvic floor. I'm joined by Dr. Lamia Gabal, a board-certified urologist with over 20 years of experience focused on bladder function, prostate cancer, sexual wellness, and hormone optimization. She was just featured on this month's Riviera magazine and was a top doctor of 2025 for Orange Coast magazine. And for those of you who do not know, Dr. Gabal is my incredible and selfless aunt who took me in after my mom passed away in 2011. I call her Tutu, but for the sake of this episode, we will call her Dr. Gabal. So welcome to Almost Healed.
Thank you. Yes, ma'am.
I want to jump into kind of what you do, the type of treatments that you offer in your office, and some sexual health and hormonal health type of questions.
Great.
I think most people think of urologists as just a bladder doctor, but you obviously do so much more. Can you please explain what you do and how you came to that specialty?
Yes. So when I was a third-year medical student at UC San Diego, urology was just kind of thrown at me as a rotation. I had no idea what a urologist did. I didn't think I wanted the rotation. I tried to give it away. I tried to trade it. No one else would take it. So I said, fine, I'll just suffer through it. And I ended up loving it. It turns out urology is not what most people think, even if you don't know what it is. Urology is not like a gynecologist for men, as most people think, because both men and women end up with urological issues. I am a surgeon of the urinary, actually of the genitourinary tract. So we deal with male and female genitals, male and female kidneys and bladders, and then men only have prostates, so yes, we deal with that. And we also deal with penises and vaginas. And so all of that falls under the purview of a urologist. My subspecialty is actually female pelvic medicine and reconstructive surgery. So I have a subspecialty board certification in that as well. And so the majority of my patients actually are female. And I deal with things like urinary incontinence after a woman has a baby and she, pees when she laughs. That's something that we can help her with. There's a lot of sexual dysfunction that happens after vaginal deliveries, and I think we're going to get into that later. But also vaginal prolapse. A lot of people don't even know that these things exist, but after you push a baby out, things tend to fall out, and I put those things back in. And so a lot of women really feel more comfortable talking to a woman about these issues because they're kind of private and difficult to talk about. And so when I was applying for residency back in 1995, only 4% of board-certified urologists were female.
Wow.
Very small number, but we're working our way up, and now we're up to about, I think, 9.5%. So we're still a minority, but there's a good reason to have female urologists. I tell my male patients we have smaller fingers than the guys, and so that's a good reason to have a female urologist. But more than that, I think that it's just being a good physician and being able to offer these things to both men and women. And
your practice, Prestige Medical Group in Orange County, California, is an all-female practice, right?
Yes, so that's our thing. I have another associate urologist who works with me, Dr. Jill Byers. She also has the same subspecialty as I do, so she's a urologist who does FPMRS as well. And we have 3 female PAs. And our staff is all women, and we're there to empower women. That's what we're doing.
And as far as sexual health goes, I know you kind of touched a little bit on it. What do you typically treat in terms of sexual health?
A lot of people come in for different dysfunctions, but we also will treat things for maintenance of sexual health. As I tell my patients, it's harder to make something work if it hasn't worked in 20 years than if we just try to maintain something. And so for men, primarily it's erectile dysfunction that we deal with, but we also deal with ejaculatory dysfunction, and then there's different anatomical things that can happen to the penis, especially if someone's uncircumcised, that we could fix if that's getting in the way of sex. But for men, it's pretty straightforward. For women, it becomes a little bit more complicated in that female sexual dysfunction usually has multiple layers, and it could be related to pelvic pain. It could be related to anorgasmia, delayed orgasm. It could be related to decreased libido. There's so many different levers that need to be pushed for sexual function in a woman, where with men it's usually just one layer, but one lever. But we really delve into all that, and we actually do hormone replacement as well for both men and women, because that's a very important piece for sexual function, is having a good hormonal balance.
And why do you think sexual health can often be overlooked for women in kind of mainstream conversations?
Well, people aren't comfortable talking about sex. And I feel like sex is sometimes still a 4-letter word, even though I know it's 3 letters. People just they don't want to talk about it. They don't feel comfortable talking about it. And especially if a woman brings something up, there was a recent study actually out of George Washington University that was published in JAMA just earlier this month, where it was like, oh, duh. But they had to do a study to show this, that 80% of women felt like they were gaslighted by their providers if they talked about sex or pelvic health or pelvic pain. And I think a lot of it really boils down to the fact that the providers don't understand what to do. And so, when I was in my medical school and in training, we learned a term called idiopathic. Idiopathic means something comes from a reason we don't know why. And one of my professors actually said, well, that means we're the idiot. And that's what we should realize, is that we need to learn more about these things. And I think there's a lot of urologists out there who don't understand, and not just urologists, gynecologists, primary care doctors, who don't understand what to do with these patients. And so they might gaslight the patient, telling them it's all in their head, or go home and have a glass of wine, things will get better, or, go talk to a therapist, when there might be an anxiety component, but it really translates into a physiologic issue that those of us who understand about this stuff can help with that.
And you're like my concierge doctor, not by choice.
Everything. Not just urology.
But I've had my fair share of struggles with my pelvic floor, and I'm so passionate about it. And I think pelvic floor health is so overlooked. And there were so many doctors who told me I was just crazy. And even though that might be a little bit true, I think that there is a lot that doctors overlook when it comes to pelvic floor health. And a lot of women I know say, oh, I just have a small bladder. And it's like, no, that's not true. You do have a bladder issue, but you most likely have some type of pelvic floor dysfunction. So for people who don't really know exactly what that is, could you explain really what the pelvic floor is and why it's essential for our health?
So the pelvic floor is a bowl of muscle that helps hold all your organs in place. Basically, it's at the bottom of your pubic bone to your tailbone, and it's a big bowl of muscle made up of several different smaller components. But in women, there's a hole for the urethra, a hole for the vagina, and a hole for the anus. And in men, there's a hole for the urethra and the anus. And what happens, and this happens more commonly in people who have back issues, but not just in those people, the message from the spine to the pelvic floor muscles gets kind of wonky, for lack of a better term. And those muscles tend to go into spasm. And we know it's exacerbated by sitting for long periods. We know that it's also made worse with stress and anxiety. I tell my patients, whenever we're stressed or anxious, we get headaches, neck aches, back aches. This has also been described as the headache of the pelvis, because everything just tightens with stress and anxiety. And in men, it can manifest as anal pain, penile pain, scrotal pain. They're told they have a big prostate when they're 25 years old, which just doesn't happen. I just saw a patient like that yesterday, when it's really primarily his pelvic floor. And in women, it manifests in vaginal pain, urethral pain, recurrent UTIs, constipation. A lot of these women are told they have IBS, and maybe IBS is the constellation of symptoms, but the primary issue is their pelvic floor. And they can get recurrent UTIs because of this, pain with sex, anorgasmia, and then there's other comorbid conditions that go along with this, like endometriosis and pelvic congestion syndrome, and PCOS can sometimes be associated with this, interstitial cystitis. So the female pelvis especially is super complicated. And again, sometimes depending on which specialist you see, you might get a different answer. But really, I believe that most of those things boil down to the pelvic floor muscle spasm being the primary issue.
Yeah. So you would say chronic stress just directly impacts urinary function and pelvic floor health.
Absolutely. And it also can give you urinary urgency, frequency, where you feel like you've got to go all the time and nothing's coming out. And all of those symptoms have to do not with the bladder, but really with the exit. The external sphincter is the pelvic floor muscle, and that's what's being stimulated.
And so if you saw a female patient who had these kind of reoccurring UTIs and complained about having pelvic pelvic pain and some of the symptoms that I struggled with a few years ago, what would you recommend for them?
Well, first of all, to see someone who knows what they're talking about in this arena, because again, not every doctor knows about this entity, unfortunately. And there are some specialists even who don't even do pelvic exams on their patients. They might dip the urine and tell them they don't have a UTI, but not really be able to help them with where the symptoms are coming from. So they have to have a really good pelvic exam in order to actually have someone feel the muscles in there and make sure, they can tell them if they're in spasm, find out if they're tender in that area. There's different treatment options that you could do at home, like soaking in a tub or putting heat on the area can be helpful. Sometimes we'll prescribe muscle relaxants, which can also be really helpful. But the mainstay of treatment for this is actually pelvic floor physical therapy. And we have a wonderful pelvic floor physical therapist in our area who I refer to a lot, Julie Sarton and her group. They are amazing. And as I tell my patients, you can't just go to Joe Blow PT Guide because they don't really know what they're doing with this. This is internal work that on women they go through the vagina, on men they go through the rectum. And they teach our patients how to relax those muscles, but they'll also do a release on those muscles that are in spasm. And I've had so many patients that come to me after that and they just say, this was life-changing. You don't know how many years I've been struggling with this, and I went to physical therapy, and after one session, I already feel better.
Yeah. And I tell all of my friends when they get pregnant, I'm like, if you don't go to pelvic floor physical therapy, I'm not your friend anymore because you are going to be so preventative in dealing with all of these possible issues down the line. And after my first few months of pelvic floor physical therapy and some of the treatments that you exposed me to, it was like my back pain was gone. It's like when you have a knot in your shoulder and you obviously are going to go get a massage. It's so obvious. It's the same idea, right? It's the same concept. You have a knot in your pelvic floor. You have a spasm in your pelvic floor. And once it's released, it's like, wow, I feel 100 times better. And people are just a little afraid of it because it is internal work. But I think that especially pregnant women, it should be on their radar more.
I agree. And, when I first bring this up with people, they'll say, oh, I'm doing my Kegels. And I'm like, no,
it's opposite.
Please don't do Kegels. Your pelvic floor is too tight. We need you to relax your pelvic floor. And that's what everyone equates the pelvic floor to, is just doing Kegels. But it's so much more than that.
Yeah. And how do you think the pelvic health impacts libido and sexual pleasure?
So, the brain is the biggest sexual organ that we have. And if you're stressed or if your body is afraid that it's being attacked because it's going to be in pain, then of course you're not going to want to have sex. And so we have so many patients, men and women, men with erectile dysfunction, their libido will go down because they don't want to be disappointed. They don't want to disappoint their partner. But if you fix their erections, wow, all of a sudden their libido goes up. And same idea with women, that no one wants to have sex if it feels like knives inside of you, or it feels like you're being attacked. And unfortunately, for a lot of these women, there's a very high incidence of sexual trauma that's associated with pelvic floor spasm. And so, yes, anorgasmia, pain with sex, difficulties achieving orgasm, all of that stuff can be related to pelvic floor dysfunction.
Yeah. I think libido can often feel like a mystery or the second priority in a lot of cases with women. It's always about the man and the man's pleasure. And I think a lot of women, especially when they go through hormonal change, postpartum or menopause, they aren't really sure what they're feeling or why they're feeling the way that they do. And so what actually drives female libido from a medical and neurological standpoint?
Yeah. So again, very complex, but it's an interplay between hormonal changes and really what's going on in the pelvis as well. I just saw a 22-year-old patient yesterday who had no libido. And for her, it really boiled down to her birth control pill was probably affecting it, as well as her antidepressants. And so antidepressants affect your ability to orgasm for sure. In fact, we prescribe them for men who have premature ejaculation. We use it for the side effect of delaying the ejaculatory function. But in people who are, who don't want their ejaculation delayed or their orgasms delayed, then it's an issue. And that can affect them. And it also, and certain class of antidepressants also has a primary effect on libido. Birth control has a huge effect on the desire to have sex, as well as the integrity of the vaginal tissues. And so what happens with any kind of birth control is one of the ways that it works is it makes your vagina dry. So then you're not lubricated and then you don't want to have sex because it's painful. And so there actually is a topical estrogen and testosterone cream that we can prescribe that's super helpful for that part of it. And so for my younger patients, those are the kinds of things that we delve into. For my older patients, people like me who are postmenopausal or even younger women who are still in the perimenopause, it does, I believe, come down to optimization of hormones. And a lot of people don't realize that for women, our testosterone is actually higher than our estrogen. When you look at the milligrams per ml or the nanograms per ml, you look at the units by which each of those is measured, you'd actually see that women have higher testosterone than estrogen. It's just that our testosterone is much lower than men, like by tenfold. That's where it should be. It should be much lower than most men. But as we age, that all changes and our testosterone levels go down, our estrogen levels go down, the vagina becomes more dry. There's the genitourinary syndrome of menopause or vaginal atrophy, which as we age, we lose estrogen everywhere, but especially when we lose it in the vagina, we get dryness, burning, itching, troubled lubrication, pain with sex. We also see UTIs and incontinence of urine, and that can all be fixed by either applying local hormones to the vagina or doing a laser. There's an amazing laser called the Mona Lisa touch, and the person who invented it said, if you ever wondered why the Mona Lisa is smiling, now you know, because that's why he named it the Mona Lisa.
It's funny.
So it's a CO2 laser that's painless that helps regenerate younger, healthier tissue.
And you go inside the vagina.
Yeah, so we do it inside and outside because the entire area is, prone to aging. And so it helps for burning and itching and all those things. And it can help for orgasmic function. Also, replacement of testosterone and estrogen in women as we get older is so important because we need those things for our brains, for our libido, for our muscle health, for our bone health. And there were some studies in the early 2000s that really did women such a huge disservice. These studies were published prematurely before their data was really looked at. It was the Women's Health Initiative back in the early 2000s. They had press conferences. This was unprecedented because they said, oh my God, everyone needs to stop taking estrogen now because it's going to kill you. Well, it turns out that their data was flawed and there were so many categories of these people that they needed to actually look at. And yes, if you're a smoker who hasn't seen estrogen in 10 years, you might have a higher risk of clotting because you smoke and your body has already had those changes that are associated with not having estrogen. But for most of us, the estrogen and the testosterone is actually protective from cardiovascular disease and stroke and all of that. So the data was much more nuanced. And once they actually feathered it out, now we're really seeing, but so many doctors, it makes me crazy because I have to speak to this every day. Yeah. So many even doctors still think, no, I'm not going to prescribe hormones for my patients because they're bad. And hormones are good. That's what we need. We really, really need that. I hope I answered your question.
Yeah, you answered my next question, so thank you.
Okay.
But I do know, so many of my friends who are even in their mid-30s, late 30s, early 40s, hormone replacement therapy is a big topic alongside peptides. And I know your office also offers that as well. And I also wanted to ask you about the O shot. Because a lot of people, whenever I'm out or about or having conversations, I literally just listen to what my Dr. Gabal says, and I think about it and it's in my brain. And then someone will bring something up. I'm like, I know this. And then I'll say what she has taught me. So
I love that I'm teaching you about all of these sex things.
So what is the O shot? Who needs it?
Yes.
And then let's talk a little bit about hormone replacement therapy.
Yes. So in our practice, I'm really proud that I brought these things into the practice. Not every general urologist does these elective regenerative things. And I learned about it for my own benefit and for my friends, but also for my patients. And as I alluded to earlier, the sooner you start regenerating something, the better. If I have a man who comes into my practice at 80 and he now has his 50-year-old girlfriend and he hasn't had an erection in 20 years, literally I'll say, I'm sorry, I can't raise the dead. But if we had started when he was in his 50s with his minimal erectile dysfunction, doing doing some of these regenerative things, then we would have had much more success, later down the line. A lot of these things rest on PRP or platelet-rich plasma. And platelet-rich plasma means we take the blood out of your arm. A lot of people don't know what PRP is. I think a lot of you younger people do know what it is.
I feel like everyone gets it done everywhere now. Yeah.
You youngins know what it is. The people in my generation aren't as familiar with it.
Yeah.
But it started in the orthopedic space where they take the blood out of your arm, spin it down to the healing factors, to the smaller very highly concentration, smaller volume of the healing factors, and then we put it back into the area that we're trying to heal. Mm-hmm. So vampire facials are kind of that idea where they do microneedling and then put the PRP on the face. There's a very, very smart man, Charles Runnels, who I'm affiliated with as well. I'm a provider through him. I did training with him. He developed the P shot and the O shot. He is an ER doctor from Tennessee who first started this is widely known out there. So he first started by experimenting on himself and his partner at the time, where he took the PRP and injected it into his own penis. And then also for his partner at the time, his female partner, injected the PRP into the G spot. And that's what an O shot is. So for men, a P shot, which stands for Priapus shot, is injected not into the head of the penis, but in the shaft on the side. Those healing factors to help regenerate younger, healthier tissue like nerve endings, collagen, elastin, and it really helps maintain and regain some erectile function. And for women, when you inject it into the G spot, which is, for those of you men who might not know where the G-spot is out there, it is on the anterior vaginal wall. It's on the top of the vagina, right where the bladder neck meets the urethra. Mm-hmm. So it's about 2 centimeters in from the opening of the vagina on the top of the vagina. And that's where there's the highest confluence of nerves. And that's why it is probably one of the more sensitive spots in the vagina for orgasming. We inject the platelet-rich plasma into that area and also into the clitoral body, and that helps to enhance orgasmic function. It helps to make orgasms easier. It helps a little bit for libido as well, because if you're enjoying it more, by direct result, you're going to have a higher libido. Yeah. But it also helps for urinary incontinence because of where we're injecting it, right there where the urethra meets the bladder neck, and it's something that's regenerative. Now, there's other newer things I don't even know if that I've told you about, but there's botulinum toxin. So most people know botulinum toxin as Botox, but that's one brand of botulinum toxin. We use Xeomin, a different brand. Yeah. And when we inject it into the penis, it helps for erectile function. And we can also inject it into the clitoral body, and it helps bring more blood flow into the clitoris and helps for orgasmic function. It lasts about 6 months, and that's called Clitoxin. So there's all kinds of that one's not regenerative, but it works quicker than the regenerative, and it's maintained for like 6 months.
And with hormone replacement therapy, is that an injection? Is it a pellet?
Yes. So for hormones, there's many, many different ways that you can actually get hormones replaced. In our practice, we do bioidentical hormone pellets. And so bioidentical is safer because it's plant-based. It looks more like what we produce ourselves endogenously. And so when you use the chemical synthetic hormones, that molecule doesn't look as much like what we produce. And there's actually an inflammatory byproduct at the end that increases inflammation with the synthetic hormones. And that's really where we feel like it's more dangerous to use those synthetic hormones. We also know if you take a hormone orally, it has to go through the liver, and then that increases your clotting factors. And so someone like me who has a clotting disorder should not be doing hormones orally, because the first pass through the liver definitely increases the risk for clotting and having pulmonary embolism and all that. But when you do a plant-based hormone, you don't get the inflammatory component at the end. You can get bioidentical hormones by creams or patches or pellets. We prefer the pellet because there's less room for error. And it's a tiny little incision that we make at the top of the butt. We put in the pellets of either just testosterone for some women who are still menstruating, and for men, of course, just testosterone. For women who are postmenopausal, we do both testosterone and estrogen. And it lasts for 3 to 4 months in women, for 5 to 6 months in men. And again, it's life-changing. It increases libido, muscle mass. I have one doctor who sends me all of his patients because he had it done. And when his patients see him, they're amazed at how he looks now.
They're like, I want that.
Yes. Yeah. And so it's just really, we all need it. We all need hormones. I'm on it. My husband, my brother, our dog is on.
Everybody.
Everybody's on hormones.
And there's another treatment that you do that you specialize in called P-Long.
Yes.
So I want you to tell everybody about what that is.
For P-Long, which actually my friend and colleague, Dr. Judson Brandeis, he developed this up in Northern California. He's a urologist up there. He named it P-long, which to me sounds like P-schlong. But anyway, it's P-long. And it is a series of PRP injections once a month for 6 months that we inject into the corpus cavernosum, so just the shaft of the penis. And then at home, the patient has to do a stretching device and a vacuum device twice a day. And it's for penile enhancement. I got really excited when I first heard about this because it really is something that men have not had a lot of good options for.
Yeah.
Women have had breast augmentation options for years, right?
Yeah.
And I think at the beginning, when breast augmentation was first introduced, I think there was some shame around it. And we've obviously gotten past that.
Yeah.
It's like, unless you've had a boob job nowadays,
It's
you're in the minority.
Exactly.
And I'm hoping that we get there with penile augmentation too, because, men, I think it helps for their confidence. It could help for their function. And there's not a lot of good options out there. The ones that were there were not natural and they're not good. And so with this, it's actually the man's own tissue that he's building, that he's elongating those cells, increasing the size of the unit by about 1 inch in length and 1/2 inch in girth. And it's permanent as long as you keep using your penis. That's what I tell my patients. The penis and the vagina are use it or lose it organs. And so you got to keep using it. And then you maintain the function and the size. So we offer that at our practice, and it's just been wildly successful, and our patients are super happy.
That's awesome. Well, you heard it here first. Now you know who to call if you need that treatment. But what's one common myth about female sexual health that you think needs to die immediately?
I think that the fact that women are not allowed to speak up for themselves about their sexuality. Like you mentioned earlier, that it's all about the guy and his pleasure. But women have to be just made stronger, just enabled to be able to speak up for themselves when it comes to their sexuality.
Yeah. What's something that you would want every man listening to know?
That it is okay to focus on your own pleasure, but it's also important to focus on your partner's pleasure. And a dysfunction is a dysfunction only if one or both partners feel like it's an issue. So I've seen lots of couples when neither of them is interested in sex, and that's okay. But if one or both partners feels like it's an issue, then whether you're male or female, you need to be able to speak up to your partner about that. And the other partner should not feel shame or belittled. And it's just a couple's issue that there are a lot of things that can be done around these issues. A lot of people don't even know that there's something that can be done.
Yeah. I feel like a lot of times, a lot of these treatments and education is like very coastal because it's kind of where New York and LA, it's like they kind of stem from these bigger cities. And so I feel like a lot of times people who live elsewhere, they get this stuff years after. And so there's just not a lot out there on sexual health and wellness. And like you mentioned earlier, a lot of urologists aren't focused on this stuff at all. They're just focused on bladder function or cancer. And so how many patients are you treating with bladder cancer or prostate cancer?
So cancer, because of my subspecialty, cancer is not my primary focus, but we do have several patients. And because, again, bladder cancer was thought to be a disease of old men who smoke only. And so when I did my training at the VA hospital in San Diego, like we saw a lot of bladder cancer. Out in the community, as I see primarily women, it's less apparent, but there are women who've had no history of smoking. And we're thinking that secondhand smoke exposure, is still an issue. And so if anyone ever sees blood in their urine, they must see a urologist right away to make sure that it's not from something bad like that. So I would say I maybe have 100 to 200 cancer patients where I have several thousand of incontinence patients and sexual health patients. Like those are the things that we specialize in.
Yeah. Well, Dr. Gabal is located in Tustin, California at Prestige Medical Group. If you guys want to book a consultation or speak to her, if you say that you listen to this podcast episode, she'll give you $50 off. I'm just kidding. I just made that up.
No, we will. We'll give a special discount.
We'll give a special discount.
Yes.
But I hope that you guys learned something from this. I hope you took something away that spoke to you or you brought something up in you that you maybe weren't aware of. And thank you, Dr. Gabal, for coming on the show.
Thank you, Yasmin, for having me. I love you too. Thank you, because it's a very important topic, and we need to make it more okay to talk about all this stuff.
Totally.
Thank you for leading that charge. Love you.